Hi, everyone. Good afternoon. I'm Professor Kevin Fenton, the President of the Faculty of Public Health, and it gives me great pleasure to welcome you today to today's Faculty of Public Health Distinguished Lecture. This is the fourth session of the Distinguished Lecture Series. Previous lectures were delivered by Dr. Maria Neira from the WHO, the Chief Medical Officer for England, Professor Chris Whitty, and Professor Kamara Jones from the United States. We are delighted today to have our distinguished lecture being provided by Professor Linda Bauld. And the panelists who will be joining us today are Professor Tracy Daskovich and Dr. Alice Kadri. I'd also like to thank the members of the Faculty of Public Health Commercial Determinants of Health Special Interest Group, established earlier this year to provide the FPH members interested in working in the commercial determinants of health a focal point and a forum to exchange information and knowledge and to signpost any relevant academic policy and practice expertise. Now, addressing the social and structural determinants of health is one of the faculty's recommendations for the new UK government as outlined in a recently published Vision for the Public's Health and reinforced and reiterated today in a Lancet publication focused on the early asks for the UK government in transforming the public's health. Now, tackling the commercial determinants of health can only be done through cross-government and cross-system partnerships, backed by strong leadership and based on evidence-informed policies and programs. I now hand over to Professor Linda Bauld. Professor Bauld is a Chief Social Policy Advisor to the Scottish Government and the Bruce and John Usher Chair in Public Health in the Usher Institute at the University of Edinburgh. Linda is a former scientific advisor to the UK Department of Health, the World Health Organization, and Cancer Research UK on prevention and public health. Linda, welcome, and over to you.
Thank you very much, Kevin, and I'm delighted to be here. I'm going to speak for around 30 minutes on this very relevant topic, as Kevin has highlighted, the commercial determinants of health, and share with you some thoughts about what the definition of the commercial determinants of health is, what does it mean, how do we interpret it in practice, and then I'm also going to share with you the findings of current research that's been conducted by my colleagues. So thanks to Tracy, who's going to share my slides. So as I mentioned, the presentation has 4 elements to it. We'll be looking at, first of all, the origins, characteristics of the commercial determinants. And then I'm going to tell you a little bit about one of the research consortia that I lead, Spectrum, funded by the UK Prevention Research Partnership, and highlight relevant research that the consortium does. Our theme is the commercial determinants. And then highlight some important key resources if you're interested in this area. Some of you, of course, joining today will be experts already, but others who want to find out more, there's some really exciting and important publications that I can highlight. Next slide, Tracy. So thanks very much, Heather. So thinking about how we define the commercial determinants of health, there are 3 sort of classic or 2 classic relevant definitions, and I'm going to tell you in a moment sort of where those come from, just looking back a little bit in time. The one in 2016, strategies and approaches used by the private sector to promote products and choices that are detrimental to health is commonly being used. But then Anna Gilmore and colleagues in an important Lancet series that I'll highlight at the end have updated this definition to systems, practices and pathways through which commercial actors drive health and equity. And when we do research and also think about practice on the commercial determinants, what we're trying to do is look at the drivers and channels through which corporations propagate non-communicable diseases. This is also relevant to climate change. Now, before I move on to some of the origins, I just want to say a few words about the importance of commercial actors in the economy and also their contribution to health. Commercial determinants is often criticized because it's seen as a very negative framing by some actors. But companies, the private sector is a vital, vibrant part of the UK economy and globally, and has a huge contribution to make, both in the supporting health of our workforce, providing good, green, sustainable jobs, producing products and services that are essential for health, and also contributing to wider society. And I might say a little bit more about that, I'm sure, in the discussion. Next slide, Heather. So let's look back in time just for a little bit. And so when we begin to look at the scholarship in this area, there's a long history. Some of the early work was done on formula milk and baby foods, and then variations over time just in thinking about how you frame these determinants. Corporate disease promotion, industrial epidemics, and then often a framing which we're used to from infectious disease, where we think about the host, the agent, the environment, and the vector, with, in some cases, commercial actors being the vector of disease. So producing a product that's harmful to health. And then you can see later in this slide other more relevant and recent definitions: corporate practices harmful to health, corporate determinants of ill health, and corporate determinants of health. And that brings us up to that 2016 Kickbush and colleague definition that I mentioned, and then on to the more recent work, which I'll highlight at the end. Next slide. If we think about the definitions in more detail, it's very important to recognize the kinds of sectors that we're talking about and how this is not all industry activity. It's not all corporate activity. As I mentioned, much of that in society is for good, but we have a particular focus on unhealthy commodity producers in the commercial determinants of health. So these are risks that we are posed to health because of the consumption or exposure to commercial products. And we've paid in particular attention to tobacco, where probably the most work on the commercial determinants has happened, and the World Health Organization has been a global leader on that through the Framework Convention on Tobacco Control and their secretariat, which I've had time I'll touch on later. But alcohol, ultra-processed food, pharmaceuticals, a lot of work in those areas. And then more recently, we've used this lens to look at gambling, firearms, pesticides, and other really important priorities for health that can be harmful. The analysis looks at the political and power structures. I'll give you an example of some publications there. And importantly for this lecture, these determinants operate at multiple different levels. So there's been a vast amount of scholarship on how commercial determinants operate globally, because they're driven often by transnational corporations. But any community in the UK, and again, I'll give some examples, can see how those determinants are shaping our health. And often there's a focus on consumer and health behavior. If you think about those products that I mentioned before, and producers often are very keen to emphasize individual responsibility and individual behaviors versus structural factors that we need to change. Next slide. And then colleagues who've studied this, just moving on to some of the evidence, have done a lot of work on what we call our corporate playbook. And that includes colleagues like Jeff Collin in my own university, the University of Edinburgh, but others where they've looked at how common strategies are used by different private sector actors producing different commodities. So they're overlapping and iterative, and they're also mutually reinforcing. And I'm going to, again, give you some examples and maybe talk a wee bit about my own experience as well. So these kinds of strategies are shaping the political environment, political and public preferences. I'll show you some data on that. The knowledge environment, that includes academic research, using the legal system, and then things that are outside of the legal system. So they may be illegal, but they just might be practices that are not ensconced in law. So these are all frameworks that are used, often overlapping between sectors. Next slide. So this is a very busy slide, and if you click once more, Heather, the little circle will come up. There we go. So these slides will be available. Somebody had popped that in the chat. There is some unpublished material in here. We just need to caveat that, and I may need to just check with my colleagues if that's all right. I'm going to show you some findings that are brand new and not yet in the journal. So the kinds of tactics that are used by corporate actors, thinking in particular about these unhealthy commodity producers, are the ones that are on the left-hand side of the slide. So first of all, this is work by colleagues who, Jennifer Lacey, Nichols, and others, who, if you see on the right-hand side of that table, they use international examples, which I think are quite insightful. But I'll give you a few from my own experience as well. So commercial actors can actively intimidate and vilify critics. And we've seen that in the UK. Tobacco control is an example where colleagues can be criticised by people who support an industry argument or maybe are coming from that sector themselves, and they try and undermine their efforts. They can attack and undermine legitimate science. And to give you an example there, when I was working with the UK government on smoke-free laws, the government asked me to produce an evidence synthesis, just a report that summarised the impact of smoke-free legislation in England 3 years on. So that was put on the website. I was at the University of Bath at the time, the Department of Health's website. And just a few weeks later, Imperial Tobacco, a few months later, commissioned other researchers to produce a report called The Bauld Truth. So my last name, The Bauld Truth, and it really was just really taking my report and the synthesis of my colleagues' work to pieces. So that was basically trying to attack the science. Reframing the debate, camouflaging action, so using front groups. If you remember standardized packaging in the UK or minimum unit pricing, often lobbies against that are not necessarily straightforward. From the bit of the industry you would expect to be most affected. Influencing the political process, so developing relationships with elected members locally, nationally, developing corporate alternatives to policies, so for example, emphasizing voluntary codes, which we often see with some of these commodities, deploying corporate social responsibility and partnerships. In the pandemic, my colleagues did a really, I think, important report, which was just through volunteers, looking at how some of these industries, tobacco, alcohol, and unhealthy food producers, were using corporate social responsibility to try and show that they were worthy actors in addressing the pandemic, but at the same time really exploiting things like marketing opportunities when people were stuck at home and ordering more things online. Regulation and policy avoidance and evasion, and that includes blocking legislation, again, like minimum unit pricing, standardized packaging, and things to do with fossil fuels, for example. So lots of examples there. Next slide. So just to move on and tell you a little bit about our research consortium, and I can see a comment from Glenn. It does overlap with vaccine misinformation. Maybe come on to that, Glenn, in the discussion. We've had a number of years. We're in our, it's about 15, 16 years now of consortium. We've been very fortunate. We started out, and many of us are still working together with the UK Centre for Tobacco Control Studies, funded by the UK Clinical Research Collaboration, for 5 years, and then a further 5 years where we expanded to alcohol. And in the most recent period, we're just coming to an end of Spectrum's funding. We were one of the first UK Prevention Research Partnership consortia funded, I think 4 in the first wave. And we decided that we would expand out to broader commercial determinants in the Spectrum Consortium. And the main reason was that if we looked at the policy practice landscape, a lot of the research findings we were producing in earlier years, we identified that actually the biggest block to progress for the policies that we knew would be effective to improve health and reduce non-communicable diseases were these kinds of commercial determinants and industry activity, which was really undermining progress, even if it was in the background. So a deeper focus on that in Spectrum. So let me tell you a little bit about new research through the consortium. Next slide. So we have, you can't read this, there's loads of information on this slide, but it's all on our website, so please take a look. We have 8 work packages, fantastic colleagues working across universities in all of these, and really importantly, part of the benefit of UK PRP is it allows us to bring policy and practice partners into a consortium. So we have colleagues from Public Health Scotland, for example, colleagues from the Poverty Alliance, the NCD Alliance. We work with the 3 main alliances where we think it's about some of the preventable drivers of NCDs, so the Smoke-Free Action Coalition, the Alcohol Health Alliance, and the Obesity Health Alliance, amongst others. And they contribute to all of these work packages. Next slide. So let's move on to some of the recent examples. The future funding that we have secured, which is on the slide here, will mean that some of the work that you will see in the next few minutes will continue under a different guise. There's not another round of funding through this mechanism, but we will maintain the work. And just to highlight a couple of the new consortia led by my colleagues, which I think are very relevant to this, the Global Health Research Group on the Commercial Determinants in Sub-Saharan Africa, led by Professor Jeff Cullen, and Commercial Determinants of Health and Equity, funded by the MRC, led by Professor Anna Gilmore, and a couple of others there, Addictions Policy Research Unit, that's Anne McNeil and colleagues, and Behavioural Research UK, which is a new consortium that I'm co-leading with Susan Mickey. Next slide. So the first example I want to highlight, just in terms of interesting new research, is the work that Mark Pettigrew and colleagues have led in Work Package 1. So any of you who've engaged with discussions, and I do in my government role as Chief Social Policy Advisor in the Scottish Government, around arguments about what next for alcohol policy and how do we reduce alcohol-related harm, there's lots of mechanisms, but one of the main ones is we need to take action on advertising and marketing. But if you look at the evidence, it's not necessarily straightforward, and industry would argue that there isn't a direct relationship between seeing an alcohol advert and then consuming alcohol, or indeed marketing increasing consumption. So what Mark and colleagues have done is take a systems approach to looking at this through a systematic review. Next slide. And they looked at a variety of different types of evidence. So this is a review of review, 43 reviews. So this is in preparation for publication, not yet published, and identified a number of different layers of influence as to how alcohol marketing can affect consumption. So it does influence consumption, but it's through different mechanisms. So individual level, as well as influencing wider social norms. And I think we would all understand that. And if you move to the next slide, Heather, there's quite a complicated model on this slide, but it will be in the publication. And I think this is so valuable. It just integrates the evidence into a systems level model. So if you think about all these effects, just children beginning to see alcohol advertising and that being normalized. If you think about the cues that dependent drinkers experience when they see alcohol marketing. If you think about the way it normalizes drinking in certain social circumstances, creating brand loyalty, for example, sending us messages about social bonding, about women's emancipation, and then also thinking about some of the parent company, the market effects, so how marketing can drive up their market share, and then these broader mechanisms, which really are about social norms. So I think a really exciting piece of work here, and I hope we can use this locally and nationally to make the argument for a stronger focus on addressing alcohol marketing. Next slide. So the next couple of slides are from Anna Gilmore and colleagues, and they come from the Lancet series that I will show you at the end. Now, again, quite a complicated slide. This is published, definitely can be available. And what Anna and colleagues have done here is just try to provide a framework for understanding the commercial determinants in a far more sophisticated way than we've done in the past. So the third circles at the top is the commercial sector, so the practices that actors engage in, and there's 7 key ones there. On the right, you see the determinants of health that we are very familiar with in public health. And so that's the systems through which health is affected. And then the black arrows that you see on that left-hand side are the systems underlying drivers of the system. So they highlight 3 in particular: norms, power, and some of the externalities. So that's to do with how policy is shaped and the tools that industry uses. So a useful model. And then the next slide just highlights in a little bit more detail how unhealthy commodity industries, and that's the 3 in particular: tobacco, alcohol, ultra-processed foods, and gambling. In this example, this is published again, this article, just looks at how these producers use the same tactics. And this is about influencing the political process in particular. So a deep dive on one part of that driver circle that I showed you before, or one part of the industry tactics that are used. Next slide. Now I'm just going to whiz through a few more examples from Spectrum. One of the things we do in the consortium is collect a lot of data, including from members of the public. And these are the smoking and alcohol toolkits collected monthly in England since 2006. Fantastic resource led by Professor Jamie Brown and colleagues. Next slide. And to show you a couple of examples of the recent findings that are relevant to the commercial determinants. The first one is about menthol smoking. So in the UK, we banned menthol cigarettes and menthol tobacco from May 2020. But when this paper was produced, and it is published, we found that when you look at 2023, people are still reporting about 1 in 7 smokers that they smoke menthol cigarettes, but they're not legally allowed to be sold. So is this massive illicit use? No, it's not, because about 96-97% of people who said they were using menthol in the survey were using licit sources, not illicit. So much of this is actually driven by 2 things. accessories, which are not banned, menthol accessories, so the industry finds a way to get around the ban, or indeed types of cigarettes which smokers associate with menthol. So just using some of the techniques that companies can use to get around what was an attempt to remove a type of cigarettes that we know is easier to smoke. And in fact, for younger smokers in particular, menthol is something that's commonly used. Next slide. So the final example, and there are many more that I just want to show from Jamie and colleagues, is a paper that we've got under review, which is looking at public opinion, which is something, if you're active in research, many of you will do, but it's important. And this slide just shows you a thing that's important to how industry activity can frame what we believe and what we find acceptable. So this is something probably a lot of you will be familiar with. You can see this is showing public support for new tobacco and alcohol policies, so addressing smoking or drinking. There's stronger support in general in the upper part of the graph for tobacco policies than there is for alcohol policies. But if you look in more detail at the slide, what it shows is that the policies that actually don't affect me as an individual, but are more about wider changes or affecting others, are things that people have stronger support for. So for example, people are in favor of treatment services, they're more supportive of health warnings, although much more for tobacco than alcohol. They're supportive of industry disclosing ingredients and activities, but they're not so sure about taxation or indeed about reducing availability of tobacco products or alcohol. And these are often policies that industry will be very vociferous in opposing. And I think that framing of that affects how we respond to them. Next slide. So I will just whiz through these next few slides, which are from Work Package 5, so Jamie Pearson colleagues. But the final one I've got shows you a link to a fantastic online tool they've developed. Jamie, Niamh Short and colleagues are geographers, and they look at how unhealthy commodities shape our environment. So in the first example here, looking at how frequently, using GPS, young children in Scotland were exposed to tobacco retail outlets. And then in the next slide, the industry often argues that tobacco sales are vital to the sustainability of small retailers. And in Spectrum, Jamie and Niamh and colleagues work with our partner, the Retail Data Partnership, to look at purchases in small retailers of tobacco through time, comparing 2016 with 2019, and finding actually that tobacco as part of that basket that people might purchase in the shop has dropped significantly. Not nearly as essential in contrast to industry arguments as you would think. And then finally, and I'll whiz over this one, the interactive tool in the next slide is a fantastic mechanism for local government colleagues in Scotland at the moment, but being expanded to elsewhere in the UK, to look at the density of gambling, alcohol, unhealthy food and tobacco retail outlets. And I was looking at this on the train on the way down. You can pop in your own postcode if you live in Scotland and really look at the availability and density of those products in your area. So important for licensing and other things. Next slide. And then our work package that looks at policy evaluation has looked in particular at illicit tobacco, which is a big issue and often on this topic driven actually by industry activity, including internationally, and just bringing us up to date in the extent to which smokers are using illicit sources in the UK. And that's by adding questions again to that toolkit that I mentioned earlier. And Tessa and colleagues are doing more work on that and also bringing in illicit vapes to thinking about their research in the future, which of course we know is a big issue. And maybe as we impose more regulation on vaping, like the forthcoming ban on disposable e-cigarettes. Next slide. And this is my final example from Spectrum, and then I'll just briefly highlight some really interesting and valuable resources. And this is from a PhD student in Spectrum. We've got some fantastic early career colleagues, again, not yet published, who looked at some of the new policies to limit the visibility, marketing, availability of unhealthy food products in retail outlets in England, and found that actually there were differences pre and post introduction of that. So actually encouraging and supporting and indeed requiring producers and retailers to take some of those products away from the till and away from visible places, particularly for children, does have an effect. And of course, today we've had some new exciting results on the further effectiveness of the sugary drinks levy, and just showing that regulation does have an impact on reducing exposures. So in the final couple of minutes, I just want to highlight some of the resources that are available, and there's QR codes for each of these. So the first thing, again, is that Lancet series on the commercial determinants of health. It's a whole series of articles. You can find out much more about the empirical work that's been done, and I think it provides a useful tool for policymakers as we look ahead to changes in the UK and indeed elsewhere, and really encourage our colleagues where appropriate to use this framing as a way to thinking about taking more ambitious action to reduce non-communicable diseases. In addition, the World Health Organization has really stepped up. We're using commercial determinants as something that they want to encourage colleagues internationally to think about. WHO Europe has been a leader in this area, and we know that colleagues from the UK, including from Spectrum, have worked with them to develop valuable materials. And I think, again, that does build on the World Health Organization's fantastic work through the Framework Convention on Tobacco Control, which has Article 5.3, a very clear article that says that for the tobacco industry specifically, there is no role in formulating public health policy. And the FCTC Secretariat has been a real leader in that area. So the last thing I want to highlight is something, or two final things. First of all, a book from Nason Mani and colleagues. So this is a digest that just really takes you through this topic in great depth. This is just produced, I think, a couple of years ago. And so if you want to find out more about this book with some practical examples, including from a wide range of countries, do have a look at that. And the next slide, I think, Heather just gives you a list of some of the disciplines that are included in there. So this is not just a public health topic, it's an interdisciplinary area of research. Next slide. And finally, if we think about the local level, and I'm sure we'll cover this in relation to the special interest group and the work that Alice and Tracy have been leading, Anna Brooke and Catherine Corner have produced what's called a Good Governance Toolkit endorsed by the Association of Directors of Public Health. And this is a practical guide with flowcharts as well, where if you think about working locally, in England specifically, but highly relevant elsewhere in the UK, you can shine a light on commercial determinants by thinking about transparency, about good governance, and about asking important questions about the kind of commercial partnerships or relationships that we have at the local level. Next slide. So this sets out what is in the toolkit, what it is, and also what the next steps that Anna and Catherine are hoping to achieve through this, including looking at how it's used locally, evaluating it, and thinking about how it can be expanded in terms of other examples that might be relevant for local government. So as I mentioned at the beginning, local, regional, national, international. I think highlighting the commercial determinants and using this as a framework to challenge some of the, what are often difficult conversations that we have about what is really affecting our health and causing much of that non-communicable disease epidemic that we see globally is a helpful way forward. So I think that's it from me. I think the last slide is just a thank you. I would really like to highlight Tracy Wagner-Risby, who helped me with these slides. I'm very grateful to her, but also my colleagues from across Spectrum who were kind enough to give me their material, and even with the unpublished work, give me permission to share that with you. So thank you, Kevin and colleagues, for the opportunity to present, and looking forward to the discussion.
Linda, thank you so much for a fantastic overview of commercial determinants of health. There is so much in the lecture. And so much in the chat as well. It really stimulated a lot of really good discussion as we've gone through your lecture this morning. So colleagues who are joining us today, welcome. We're so pleased that you're here with us for Distinguished Lecture. As you will recall, for Distinguished Lecture, we have a time to get to know our lecturer a little bit. So we'll now have time for a few questions from myself to Linda about her career and elements of her lecture. And then following this, we'll be inviting respondents questions to reflect on Linda's lecture. And following our respondents, we'll open it up for wider questions. So if you'd like to ask a question today, please drop it in the chat, and we'll be coming back to those questions a little bit later. So, Linda, you've taken us on a real journey and reflection on, over the past few decades, how our thinking about commercial determinants of health is evolving, how the theory, but also the practice is changing as well. And over that time, we've seen more and more industries both be included within the banner of commercial institutions, which may be having a negative impact on health, but also we're seeing similarities in their approaches as well. But I'm going to start, Linda, with just a few reflections from you as a public health leader. We have on the call over 200 public health practitioners, and I know that for many of our colleagues who are joining us, we're always keen to hear of the personal story of our lecturers and how you actually got to this place. So I think the first question, I wondered if you just reflect a little bit on your journey in public health, what motivated you to come into this area of practice, some of the values which underpin the work that you do, and how those values are manifesting themselves in your work today.
Thanks very much, Kevin. I actually think this is a timely moment to reflect on how I got into public health, because it was in 1997 that so I had done a PhD in social policy on health policy, and I moved to a UK government-funded research unit that was based at the University of Kent and the LSE. And when the new government at the time came in, they published a white paper on tobacco, and they put quite a lot of resources into public health research. So I had an opportunity to lead a small study on the setup of stop smoking services, which was different from what I'd done in my PhD. I got really interested in that primary prevention, such a harmful driver of disease, leading preventable cause of death still in the UK, and biggest contributor to health inequalities. I just got really enthusiastic about it, Kevin. Found people to collaborate with, moved to the University of Glasgow, Bath and Stirling before coming back to Edinburgh, and built up a portfolio of public health research, really by learning from others, fantastic mentors, and then I think expanding beyond nicotine and tobacco to think about some of those other products that I mentioned in the talk. But when you do that, and there's difficult times, like the report I mentioned that was criticized, and I've had other examples, but many other colleagues do as well. It's not a popular area always to be doing research in, but I just felt the harms were so great, and so many of them were preventable, that it was a valuable field to be in. And yet, so ever since then, so I was a young researcher then, I've been really committed and stayed in the field ever since.
Mm-hmm. Yeah. And, one of the things that I've enjoyed in our relationship and the work that we've done together is you are a clear academic public health specialist and leader, but you work so closely with your colleagues working in service public health, really thinking about implementation and impact. Why is that so important as an academic public health practitioner to you, Linda? And what are some of the ways in which you think that we should be building on both your experience and the experience of other academic public health specialists to really strengthen those relationships between academia and service public health?
I think, and often in academia, although public health as a field is very applied, we maybe don't have the impact on practice or policy that we would wish if we're just in our university settings. So that's why collaboration is so important. So one of the things I've learned a lot from is actually stepping out of universities and having secondments and periods with other organizations, as you mentioned at the beginning. And actually I started that during my PhD. I was doing work with part of government. So a secondment to Department of Health, 7 years with Cancer Research UK for 2 days a week now, working with Scottish Government, a brief period twice with different bits of the WHO. And I think and then fantastic collaborations with local governments. So I work very closely with COSLA in Scotland. And for me, it's actually about making a difference, because we can generate the evidence through empirical research or scholarship. But unless it's relevant to local people and relevant to practice, it doesn't make a difference. So I kind of like to get inside the tent. That's not for everybody. But it's for me, that's important, and it's something I'm committed to continue to do.
Yeah, and it's really, I'm glad to hear you say that, because we are often so challenged in thinking about what's important in making impact, driving impact, how we work with governments to actually change and influence policy. And perhaps it's particularly relevant now as we have a new government, and a government that is looking for opportunities to improve and accelerate improvements in the public's health as well. So having that academic service relationship, I think, is going to be key. And I think my final question, which I know many of our younger or registrars or those who are starting their public health careers will want to hear from you, Linda, before we get into the commercial determinants of health, is looking back on your career. Um, do you have, what would your top 2 or 3 tips be for young researchers coming up, or young public health registrars coming up who want to have that combined career, an integrated career in academia as well as in service public health? Anything from your experience that you would reinforce? Thanks.
So there's always sort of three things I point to, and they're very generic, but for me they were important, and I think they're relevant both in academic public health and in practice. The first thing is really to find those mentors, those allies. I think having a mentor or different mentors through your career, you learn a lot from others. So that I found that very, very powerful. The second one actually is having a specialty or being very true to your field. So I think building up expertise. So in public health training, particularly for registrars, you're covering health protection, health improvement, health services. You know, you've got to do that training in all aspects of public health, but you will find a domain or an area that you're particularly passionate about. And I think building up your expertise in that, even if through time you shift, is really valuable. And then the third one, I would just say, going outside of our comfort zone, taking up those opportunities in academia, you know, it's
Exactly.
editing a journal or all these different things, just help us grow and learn, make a difference that way.
Fabulous. Thank you, Linda. So I'm going to shift us now to some specific questions on commercial determinants of health, and to drill a little bit down on your lecture. Again, in lieu of the fact that we have a new UK government, one of the questions that we're going to be asked is what can be done both quickly and at low cost that the government should be considering to actually move this and other agendas forward. Um, from your practice and your research, what would you say? Low cost, high impact interventions with a strong feasibility of implementation that government should be considering at this time. Where would you point the government to, or policymakers in general, in dealing with the commercial determinants of health?
So the first thing I would start with is there's been lots of policies on the books that we've not seen implemented, which are, many of them are about regulation or population level. I mean, dealing with addressing overweight and obesity and promoting healthy weight. I think, you know, if you think of preventable causes of NCDs, we are nowhere near where we need to be, Kevin, as you know. So we need this new UK government, and I would argue the same in Scotland, to take much more ambitious action on regulation to address the unhealthy food environment. And we know what those 4 Ps are: product, place, price, promotion, the marketing mix. So we've got things on the book. So let's progress with the stuff that is already proposed. Of course, I would say the smoke-free generation, tobacco and vaping legislation that we must drive through as an absolute priority, and it's almost there. So let's start with the things that we know. The second thing I would mention actually is devolution and local
Mm,
support for action. Because if you look across the UK, again, just sticking with the food example, Transport for London, some local authorities in England that have taken action on outdoor marketing, these are things that can be done locally. And so I think using that lens, the local lens on the commercial determinants, including actually through anchor institutions, which we might have some time to move on to later. So those are the 2 things I would start with.
yeah. Excellent. And I think those are really critical. And I think your reinforcement that there is a body of literature of effective interventions which are not yet implemented at scale. And I really liked your reflection on local support for action, and we'll definitely come back to that. In the chat, there were a number of comments about, does the terminology prevent people from both understanding and engaging with this really important issue? And is there a way for us to be thinking of a different, more consumer-friendly terminology for commercial determinants of health? What are your thoughts on that?
So the first response is yes, it does. I mean, the term unhealthy commodity producers is just not, I mean, that's really, it causes a lot of bristles. We use it, I think it's a correct term, but in some circles it's a problematic term, and it's a bit like that with the commercial determinants. I thought that Alice and Catherine using the title of the Good Governance Toolkit, but using the commercial determinants as a framing tool, it is about good governance in terms of their guidance and advice with other colleagues. So I think we do need to change our language sometimes. I'll give you a practical example, Kevin. There's been discussions in Scotland about using this framing to think about conflicts of interest for different parts of our system. Public Health Scotland, a leader probably in this area who can do much more. They are quite comfortable with the term commercial determinants. But if I talk to my colleagues in Net Zero or DG Economy in Scottish Government, it's maybe not such a useful term for thinking about all their interactions. So transparency, governance, other things that we can use. Let's not water it down, but let's recognize if we want to achieve change, we need to take people with us. And that means using a framing that is appropriate for the context.
And I think in that respect, one of the things you and I have spoken about as well is that by saying commercial determinants of health, we often go to a negative frame in terms of the role of business, and at a time when policymakers are so focused on economic development and growth, managing that balance between actually, yes, you can have growth, but it can be good growth, and here's ways in which you can do it. So there's something about how we link narratives in ways that are helpful. Another key question that is coming up is just about, in a sense, clarifying that the locus for intervention for the commercial determinants of health do not only rest at the national level. And you alluded to that with some of the local devolved actions, but I wonder if you could speak to that a little bit more, especially as you raised earlier, the role of anchor institutions as well, because multi-level interventions on commercial determinants of health are critical. So could you reflect a bit on that? Thanks.
Yeah, I will, but also just to say something quickly on your point you just made. I think we do need, economic growth, and driving that is absolutely essential. And the Marmot and colleagues, of course, produced, I think, the Business for Health Equity report, if I'm remembering the title correctly, Kevin, and that really sets out how business just plays a vital role, as I said out in the beginning. So I think that's important to recognise. So local action, there's lots of different ways to think about that. So I mentioned anchor institutions. When I'm talking about anchor institutions, it's not just the NHS and local government. Local businesses can be anchor institutions. So they can think about responsible, sustainable practices, providing healthy food, thinking about their procurement frameworks. Those are all things which, again, thinking about ethics and greener approaches and the best policies are something that can be done locally. So that's an area of action. Procurement, land and assets also to some extent, but then I mentioned those examples where local authorities have thought about the tools that they have, whether that be, for example, the planning system. So local planning, licensing, those kinds of actions that people can take in local communities. The other area, which again the Good Governance Toolkit highlights, is just thinking really carefully about the partnerships that we take up locally with different organizations, making sure we have due diligence, and also promoting partnerships which we think are going to be good for the local community and are relevant to local people. So there's lots of things, but in terms of local action, I think when we come to Alice and Tracy, they're going to have some fantastic examples that they would wish to highlight from their areas of expertise.
So over time, Linda, we've been adding more and more industries, it feels, to the list of commercial determinants of health actors. And I wonder, in an era where social media could probably be added to the list, should we also be looking at artificial intelligence as an emerging industry, and both the impacts that it's having on the environment? There have been recent reports over the weekend about the the climate impacts of the energy required to run these large models for AI, but also the damage that AI may be occurring in a number of fronts. So my question is just about understanding how we ensure that we're continually both surveilling and understanding the environment and new and emerging industries and bringing them under the tent. And my second question is, as we identify new industries where the commercial determinants of health might be relevant, how do we move faster rather than reinventing the wheel each time in terms of generating the evidence, thinking about our approach, engaging with policymakers, etc.? Are we becoming much more efficient in how we can raise alarm, generate the evidence, and provide evidence-informed actions to help governments to act? Because we are seeing new players coming onto the market, and I wondered if you had any thoughts on that. So two questions again roll into one, but over to you.
So I think one of the things that we are good at in public health and we need to continue to do is to identify robust frameworks that we can then transfer to other relevant areas or topics. We do that a lot in infectious disease, don't we? But we could do it in this area as well. So we have the terminology, despite the need to be flexible in that, as I described. We have the scholarship. So I think it can be adapted, and you'll see that in the examples I gave, to new and emerging technologies. So again, just thinking about the last couple of days, Kevin, colleagues engaging with Ofcom around some of the questions they have around online regulation, a colleague again who's doing research on online child safety. So all these new technologies about which I'm no expert, I hurry to emphasize, I think can be adapted. But let's be careful as well. So let's use the same models, let's be nimble, but let's collaborate across areas. Let's collaborate with the people who are experts in AI, but maybe haven't thought about this framing or this interrogation of it. And I think that's one way to be efficient, is to do those collaborations. But let's stick to robust frameworks. Let's not dilute the science, because I think that is what lends credibility to the arguments.
Fantastic. And in the chat, you'll see other colleagues suggesting other industries that may need to be added, including the auto industry as well. So I think in my mind, it's both understanding the role of commercial partners, the criteria that are used to understanding their impacts, both positive and negatives, and then the frames that you use, as you rightly say, Linda, in applying how we understand their impact and how we apply policy action. So, Linda, thank you so much. It's been fantastic speaking to you and just getting a little bit more about you and learning a little bit more about your career and what drives you as an academic public health specialist, but also to explore some other aspects of commercial determinants of health, picking up some of the initial comments that have come in the chat. So at this point, colleagues, we shift gear a little bit, but only because we want to bring additional panel members to the fore to introduce them and to widen the conversation on commercial determinants of health. And I'm really pleased that today our two respondents are Professor Tracy Daskovich, who is the Vice President of the Faculty of Public Health and the Executive Director for Public Health and Strategic Partnerships in the Aneurin Bevan Health Board in Wales. And Tracy is also the co-chair of the Commercial Determinants of Health Special Interest Group in the faculty. And Alice is a Public Health Specialty Registrar, an Honorary Research Fellow at the London School of Hygiene and Tropical Medicine, and she's co-chair of the faculty's Commercial Determinants of Health SIG. Tracy and Alice, welcome, and we'll start with you, Tracy, for your reflections on what you've heard, the discussions, and any key points that you'd like to land with the listeners today.
Oh, thanks so much, Kevin, and thank you, Linda. It was an amazing presentation and talk. And I think for us, I think what your talk showed to me was the length of time that the research around this area has been going on. Yeah, it only feels that it's coming to prominence in wider conversations and wider considerations around public health in more recent years. So just that depth of knowledge and scope that you shared with us was key, both in terms of the work that we're doing in the special interest group, but in terms of how we plan, in terms of the applied science around public health in the planning more locally as well. So I took a huge amount from that. I think one of the things that came through really clearly for me was the influence that marketing had, and obviously you were applying this in this context to the tobacco industry, but what you were shown in your talk was very much about that speed that the influences and the normalization of behaviours take place. And I think that's one of the key things we talk about when we talk about public health policy. We often get accused of creating a nanny state by giving people information and advice on how to improve their health and well-being. But what you see conversely in terms of the commercial determinants of health is how that marketing actually influences decision-making in a different way, but takes hold in a different way. And I just think the comparison between those two things is fascinating. So I think there's something for me in terms of what I'll be taking forward from the discussion today is how we can learn more from in terms of the sophistication of the way marketing happens and how we think about that, the way that impacts the influence, the framing of the way that does in terms of the way industry sells a lifestyle, and how we could frame things in a different way and think more differently about the way we do our public health interventions to almost mirror that for a very different outcome within that space. I also, and again, it all links back to pace, doesn't it, in terms of the way that the commercial industry can operate and adjust. The pace of change you talked about in terms of the example you were using was around menthol cigarettes and the way industry adapted so quickly, that pace of change, to find a way of accessorizing that, to still make that a commercially viable route through. So people were still, despite the product being illegal, we're still able to do that in a legal way, which is just fascinating when you just think about that. And we see that all the time. You know, we could track this back to the emergence of ultra-processed foods. We could do this with alcohol. We could have a very similar conversation in terms of that change. I think for me, the main message is one I've touched on in terms of how we do move that framing. And one of the things that we're doing through the special interest group is to bring together that academic influence, that policy, and our conversations indeed around industry to really inform this, and the way that we're inviting faculty members to come into that conversation. I think we can learn a huge amount from each other. Just in this last half an hour, I've taken copious notes to do further reading and to learn more. And I feel like I've read a lot in this space over the past year to 18 months. But there is just so much more we can do. But I think it is going to take all spans of public health to galvanise around this as a key issue for changing health and wellbeing for our communities in the long term. But thank you, Linda. It was an amazing lecture. Got a huge amount from it, so thank you so much.
Thank you very much, Tracy. And Alice.
Thank you also, Professor Bauld, for that wonderful lecture. And I think it's a great chance to pay tribute to the academic who sort of part of the system who has done work on this for so many years now, and built up such a substantial body of evidence that I feel very deeply committed as a professional to now bringing that into the practical space. And that brings with it a new set of challenges, I think. And of course, we are also really inspired by, you know, the DPHs around the country who are already in that space and doing that work, working at the local level and using the levers that they have. And I thought, gosh, there's so many things I could reflect on, but what I thought I would try and do is I just want to talk through a little bit of my personal journey, a bit about where the penny started dropping for me with commercial determinants. And I think this links back to the language that can be off-putting or perhaps inaccessible about it. And I think, so I was going to tell you how I kind of got there to my understanding of how really what I'm quite convinced about is that commercial actors are now attempting to shape health for good or bad at every level of our system, and how we have to be wise to that. I came to public health really as a reaction to clinical medicine and the difficulties, I think, of working in a system that is straightened, that and treating people who kind of have what are clearly preventable illnesses, and for which medicine and healthcare does not hold all the answers. So I had that very strong emotional reaction to clinical medicine. And of course, public health holds so much promise of prevention through our universal work, through our targeted work. And through the sort of earlier journey as being a registrar and getting sort of clear about where our policy levers are in the system, I do feel critical of ourselves that we still are largely occupied at the individual level, and it's very hard, very challenging to try and work at a systems level. And as a result, I do think that's why we see outcomes worsening in some cases. And I think we all know, for example, the increasing deaths from alcohol, deaths that are wholly attributable to alcohol, are still worsening. So the first part of that penny dropping for me was understanding that we live in a system, we work in a system, and of course the social determinants of health. We've all absorbed that. We all feel that as practitioners as well. That explains some of the preventable causes of illness, and we understand that they're largely beyond the individual's control. Whether this is housing, the availability of good work. And it allows us to access that, understand the building blocks of health and how influential they are, how unevenly distributed in the population they are. But I always found that social determinants as a concept, as sort of way in, doesn't explain far enough that there are power dynamics in the system, that we live in a complex system. And what that means to me is that when a system is complex, that you might make a change somewhere in the system, but it adapts around it. And that the outcomes that you see, population health outcomes, they are nevertheless the product of the system as it stands. And we can say the system is designed to produce the outcomes that it gets. So we have to ask why do we still get these outcomes with our system? And so it is that sort of journey that took me to commercial determinants, because I think that through the evidence that's come through, especially in the last 10 years, that's really crystallised, is this understanding that public health policy making and the political environment, the Overton window, is very much permeated by industry. And we know through all that evidence that industry actors can take action at every level of the system. And we do have to preserve that sense of, industry for good and positive outcomes as well. Industry is necessary in our ecosystem, but I think it's important to understand that they will act to preserve profit at the cost of other goals that we might have. And we've seen that visible through the sort of poor outcomes of partnership working, and the shortcomings of industry-led initiatives, shortcomings of self-regulation. They have framed themselves, tobacco companies, alcohol companies, as good actors in this system. And as a result, we've all lived through a period of time in which they're considered to be legitimate partners in health policy making. I think they are still considered legitimate partners, but we are questioning that because interests are not fully aligned. And we just saw reported in The Guardian, I think earlier this week, the actions that were taken by tobacco companies to try and put the previous government on notice of legal action around the tobacco and vaping bill that was planned. And so I think that it was at that point that I was thinking that we really I was going to pay tribute to my colleagues Anna Brooke and Catherine Corner, who did all that work on the good governance framework, absolutely brilliant work. And it took me a long time to realise how apposite that was, that they picked that piece of work to do. And it's because conflicts of interest work is so foundational, I think, at the moment. It is where the norm, I hope, will shift. I think we need to move beyond declaring conflicts of interest to managing them and to interrogate them with a little more of a critical eye, because we have seen evidence that even our evidence base, this is our area of expertise, even the evidence base is permeated by industry interests. It isn't secure always. We have to be able to kind of critically appraise the evidence that we read, if it's funded by industry actors and so on. So we need to think about how we can use conflicts of interest to safeguard our evidence and our policy making and our discourse as well. And good governance is an effective way of doing that. And I think finally, the comment for me on the SIG is that the commercial determinants of health SIG that we've now set up, and we're definitely working towards more specific aspects of a work plan, is all about supporting our colleagues and bringing together a skills base that they can draw on to draw confidence from and competence specifically, and cross-fertilise between academia, practice and the policy advocacy type of work. And I think we've got a lot of energy there for that. Thank you.
Alice, thank you so much. Wonderful reflections, and thank you for sharing your own personal story and your own personal journey on the road to understanding and embodying work on the commercial determinants of health. I think for all of us as practitioners, reflecting on our own journeys in different aspects of our public health practice is such a key way of both accelerating our learning, but also identifying and challenging ourselves to areas for development as well. And Tracy, lots of positive feedback on your comments around how do we frame, how do we get pace on this, how do we learn more effectively, and how do we raise the sort of bar when it comes to the quality and impact of our practice in this space. So we have a long list of questions in the chat, and thank you to all of our attendees today for being so proactive. I'm going to start with one on the curriculum and training. Maybe Alice, to start with you, and then hearing from Tracy and Linda about, there's a question from Paul Batchelor about what does the panel see as the role of healthcare curricula in building the case to challenge existing practices. And Alice, as a registrar, what was it like in terms of the curriculum on this issue? Could it be strengthened? Where could it be strengthened? And I'd love to hear from you, Tracy and Linda, in terms of what more can we do for public health and all registrars and trainees in health. Alice?
Yeah, I think it's a great question, because I think the curriculum isn't specific about commercial determinants, and it's emerging definitely to me that there are some specific skills that relate to commercial determinants work, and I think particularly they relate to that confidence around how you govern public health policy making. So obviously there's plenty about the evidence base and the understanding and critically appraising evidence, but there's specific elements relating to what it means if when industry try and get involved in that. That could be strengthened. And the second part of that is because I think there's a lot of fear around acting in this space because of legal challenge and pushback, whether it's locally, regionally or nationally. And we need to have confidence about that. We're not lawyers, and we need to know where we are standing steady on, sort of sure ground, and have confidence to act from that ground.
Thanks, Alice. Tracy, any reflections on curricular development for this?
Yeah, I think it's a really important question. I think it's about recognising the span of that curriculum and where the influencing points are within that learning opportunity. I think there is still that space in terms of how we build what we learn in our world. And obviously we're constantly in conversation with like-minded people, so they're very straightforward and easy conversations. But how do we expand that into wider systems and take that learning into that space? If I think about healthcare, how do we make health happen outside of healthcare services? We know that that's where we're going to have the biggest influence. So thinking about how we build that in, and how we can influence across our systems from what we build within our own learning and take that forward more broadly, so it can still really start to embed the causes of the causes in every conversation that we're having.
Yeah, and that's why I think the SIG in the faculty is such an important development, because it creates a focal point for some of that learning, that dissemination of best and promising practice, and ensuring that even if trainees are not getting it in their development through the SIG and its products over time, there will be another source of information on best policies and practice that we will have for members as well. Linda, do you have a curriculum already prepared that you could share with us, or something off the shelf? What is your thinking on this?
No, there's some fantastic materials. So again, I mentioned Mark Pettigrew. He's got a wonderful module at the London schools, but there are many others. And I see if feeling slightly intimidated, Kevin, by seeing some of the expert colleagues who joined us and have put in comments in the chat. So there's a number of people who've got deep expertise on gambling, for example, in commercial determinants, alcohol and commercial determinants, who are with us today. But on the curriculum, I just want to say a couple of things. The first thing is, for trainees, but also looking even earlier in the pathway, those that are teaching undergraduates, including undergraduate medical students, who I try to encourage to think about public health as a specialty. They're incredibly enthusiastic and keen, and actually they get this when you discuss it with them. They live in a commercial environment. They see these influences. They're often very keen to be political about it, and they get very angry when you start explaining some of these things by using rigorous frameworks to describe it. So let's harness that. And it isn't always young people, but people who are enthusiastic and keen. The second point I would make is Alice made a very powerful point about the social determinants and how that is well understood in public health. It's a framework we all know. It's part of our training. We recognize it. I think we need to embed this further in curricula so it's understood in a similar way, underpinned by robust research. And then my final thing is just about the legal aspects, which a colleagues also put in the chat. Alice was saying, well, we're not lawyers, but I think increasingly within public health, we are looking at legal aspects of the public health system and trying to give our trainees some understanding of how the law interacts with the public health system, not just on this topic. So I think there's more that we can do there, and also more broadly empower our colleagues to collaborate with people, because we've got some fantastic legal scholars in the UK who are interested in this topic and have done work on it. But great question.
Wonderful. There's a question from Alison Douglas, which is from the alcohol focus, which I think is pertinent given where we are in the political cycle. And it's with both UK and Scottish governments emphasising economic growth as a fundamental priority. How do we ensure that public health is not seen as being in opposition to this? And how can we play a role in a just transition away from health-harming industries? Tracy, I'm going to start with you, maybe Linda, and then Alice, if you have any reflections.
It's a great question. It reflects a conversation I've been having locally as well in terms of the absence of health economics in a lot of our conversations. We talk a lot now in terms of public health planning, touching on that social, economic and environmental space so that we can cover all the determinants within that conversation. But I don't necessarily feel that we possibly do that equally. And we know that building a strong economy now is really vital for improving health and well-being, and how we can really embed that within our community growth as well. So, you know, and this starts with education, you know, good jobs, and that route into economic prosperity. So I think this is one of the conversations we've really got to strengthen in here, and I think health economics is the bit that's missing from this conversation, and it's hard to bring into the conversation. It seems to be the discipline that isn't prominent in all of our conversations, and not easy to bring in as well. It's a specialism that doesn't seem to have the same prominence it once had, and that could be that we still have the experts out there that have specialised in other things that have been more pressing over recent years. But how do we bring that conversation of health economics back to the fore to really start and reinvigorate that social return on investment?
Great. Thanks, Tracy. Linda, your thoughts? I
mean, the faculty's vision actually begins to touch on this. So the mechanism currently, the way in is through the productivity discussion and economic growth. I mean, the evidence is so overwhelming of the effects of health-harming products, but also non-communicable diseases and mental health more broadly on our workforce and people of working age. You know, we just see where the UK is. So I think that's in my government work, that's a really helpful, and Alison knows this, she knows the landscape very well. That's a helpful way into this, is to argue that we need to be ambitious and we need to use regulation. Otherwise, we're thinking about our expenditure on social security, you know, all the other parts of the public purse, not just the NHS, that are affected by a workforce which is not where it needs to be in terms of health. And commercial determinants are just part of that. So that's the first thing. The second thing I would say is that it's a policy coherence issue. You're always going to have pushback, I think, from different bits of government. Well, anyway, without naming bits of government, who naturally feel quite nervous about anything that looks like it's anti-business. But I think by having cross-government, cross-policy conversations, you can help colleagues to understand actually that there are different types of evidence that are relevant and all of them need to be considered. So that would be my first thought to Alison's question.
Lovely, thank you. And Alice, any reflections on the question?
I think it's essential that we're not seen and aren't anti-business, but I think it's important to kind of unpick what kind of business we're talking about, like the small business and a locality that is a source of local jobs and well-being through that kind of good work. It's completely different to a very large alcohol transnational who is arguably really not a source of growth, certainly not at the household level. So I think that when we have this kind of political discourse about economic growth, it's often kind of slightly, it's not, you don't get to hear growth for whom, you know, who exactly is profiting from this growth, where does that money actually go? Does it go to households? Is that where we're seeing, because that's not what's happened, you know, in the last 14 years. So I think it's about, you know, being able, I think we will get pushback regardless of what we say, because you start from the frame of being a public health person and people kind of respond to that. But I think it's important to have a slightly more nuanced response about what is good work, what is good economic growth, and a well-being economy is the goal.
Mm-hmm. Great, thank you. So I'm going to ask each of you to respond to the questions now, given the time that we have left. So we'll pick up questions and maybe any volunteers who may want to tackle these. So the first is from Mary O'Brien, and I think this is about ways in which governments work with industry. The previous governments set up food data transparency partnerships. There have been a number of industry government partnerships which have been used to either look at the metrics on how large retailers are making progress or to nudge behaviors within industry. Are you confident about the opportunities for any new government and for this new government to shift to a more policy legislative approach, or might you see that this much more the alternative approaches might be something which would be preferred or implemented? It's hard, none of you can speak for the new government, but I guess at the core of the question, it's about, we know that there are different models. How do we encourage a new government to both build on the best evidence and to use the most effective models for engaging with industry? So Linda, I'm going to perhaps start with you with this one and then see if there are others who would come in.
I mean, yeah, this is a key question. This is a very, very tough area to work in, and it's a very tough to make the argument. So I don't think we should assume that any of this is going to be easier just with a shift in the UK government, because it's just tough stuff, particularly the policy coherence piece I just mentioned. But I do think we've got a lot of evidence about how those partnerships have not gone well and not yielded benefit for public health. The responsibility deal being, I see Teresa Marches joining and asked a question. You know, colleagues who've got the scars and know how challenging those kinds of partnerships are. But it's a fresh start now. Let's make the case. Let's use the evidence. And I also think that the challenges, the problems that we have are so grave in relation to the workforce, in relation to health, and in relation to the lack of activity in some of the regulatory issues that I mentioned before, that we really hope that government will see that this is the time to take more ambitious action and to have the confidence to push back on some of the default voluntary codes or partnerships where they're not appropriate. Final thing is, of course, partnerships are appropriate in lots of ways sometimes with commercial actors, just to emphasize what I said at the beginning, but it's about making sure that governance is correct and we know where the real conflicts are and where it's not appropriate for those partnerships to be in place.
That's right. So, you know, I often say, Linda, that, you know, organizations should have clear policies which dictate how they're going to engage with industry, that those policies should be transparent, that there should be a robust governance process, there should be proactive checking, rechecking of the policy against practice over time, because things and the environment and the context changes. And there should be an evaluation about whether the anticipated gains and benefits from the policy and this approach have been derived from this approach. And so those are some of the conversations that we're having internally in the Faculty of Public Health as well, as we explore whether or not there are opportunities for us to partner with different commercial partners in a way that enables us to look at expanding the offer to our members, to think about work in specific policy areas, etc. But Tracy and the SIG will be helping us to develop our working with industry policy in the faculty. These are important questions for us, whether we're working at national or local levels. Tracy, I'll invite you to come in on this one as well.
Thanks, Kevin. I think this is almost the exam question that we all need to be working to, isn't it? It's a great question. But I think, just briefly, I think the thing it brings to mind is I think this is such a complex area that no one approach is going to work in isolation. So, you know, if the food data transparency partnerships are successful, that doesn't negate the need for policy. And I think we'd need both of those things in that space. But I think the other thing that we miss is also about how we get in a consistent way into that planning space. We know that we can influence an awful lot, not necessarily around the big food suppliers like supermarkets and things like that, but also around the fast food outlets and other things like that. If we could truly get into that planning space in a more consistent way, then that would be another way of influencing this. And some areas have succeeded in that, but other areas haven't, because again, it's not a legislative level where we have got permission to be at all of those tables in a consistent way.
Yeah, excellent, thank you. There's another question and another sort of area that I'd like to explore with the panel, and this is the international dimension on commercial determinants of health. So a number of colleagues have reflected on, there's a question from John Middleton and question from others around many of the actors themselves, commercial actors, are multinational companies which may be sharing policies, implementing policies which are harmful to health in many different jurisdictions. And even though we may have gains in one area, it's not necessarily changing practice globally. But there's another aspect of the international connections here where you have think tanks, which may also be influencing policymakers' thinking on commercial determinants of health, or maybe facilitating the actors themselves. And I wondered, to what extent do you think that the work that we need to be doing, I mean, it is a big agenda, should be focused both domestically, but also we should be keeping a close eye on it as a global health issue as well. So open to the panel. Alice, I'm not sure if you... Linda, you want to start with this one, and then we'll get to Alice. Thank you.
Sorry, unlike Tracy, I had to figure, I need to be able to raise my hand to volunteer. Boy, those are big questions. So I think on the international, so there are many, as Alison rightly points out in the chat, there are many, even actually within the UK, in a devolved context, the single market and other issues have prevented SG or made it difficult for ScotGov to maybe even think about action on some issues that certainly arose in the vaping space recently. But internationally, that's very much the case. So international trade is a big issue. So the UK government's hands can be tied on taking action on some of these things. So that is a factor. And that's why I think that a lot of the scholarship that's been done in this field, again, has been done internationally. From a public health perspective, that's why it's so welcome that the World Health Organization is showing more interest in this area. But of course, they don't have power to change laws or change treaties necessarily around trade. But I think if the WHO, by working with other intergovernmental organizations on this, at least can raise awareness. So that's a legitimate thing. And then on the think tanks, absolutely, we've always had support and argument from think tanks which are funded by commercial actors that we don't necessarily know about and often operate internationally. So I think, again, collaboration is probably the way to go when we're thinking about a UK public health workforce. Let's keep that global focus. Again, back to the faculty's vision and the work that we're doing. So for the special interest group, I'm sure Tracy and Alice already thinking about this, the connection between this special interest group and the work that the faculty does globally, I think is going to be another layer to this.
Wonderful, thank you. Alice, did you want to comment on this as well?
I think my initial response to the question is that it's such a huge question, and invokes huge international actors on the side of the kind of transnationals, and also these arenas, legal arenas that I don't access, I don't understand how they work. But the real hook, I think, here, the second thought was, when we, as just members of civil society, understand better how these sort of transnational actors actually behave at this level, and the degree of basically sort of interference that they try and enact by using like legal levers to disrupt basically one country's sovereignty, and they want to kind of create public health policy in their country, and it's disrupted through the mechanism of an international trade agreement. I think that sort of behavior, when people are aware of it, is it's considered to be quite egregious. People are angry about it, and it reduces that kind of social acceptability of that brand, of that firm, in our country as well. So I think people do feel a sense of collective anger when they hear about these things. So so not only do I agree with Professor Bauld about, yes, I think it'd be great to find ways of collaborating internationally. I think this is also about collaborating with civil society so that we understand the activity itself.
Yeah. Brilliant, thank you. We have time for one final question, and I'm going to sort of amalgamate a few questions, because I think colleagues have been suggesting different industries which we should be looking at, including the car industry, fossil fuel industry, gambling has been mentioned, social media. I guess the question to the panel is, to what extent do we focus on the sort of big determinants, tobacco, alcohol, food, as the core area of our public health focus? Or to what extent do we begin to be more agile and to look at emerging industries, new industries, including digital, social media, gambling, which is newly emerging? Where's that balance of time and effort? Is there a way in which we should be thinking about where we place scarce public health resources in this work? So I guess my question at its core is, do we continue to focus on the things which are driving morbidity and mortality, smoking, food, and alcohol? Or do we find that space and create that space to looking at new and emerging drivers in the commercial determinant space? So who would like to start with that and give your closing comments as well? So I'll hear from all three of you now. And seeing no hands, that means I'm going to start with you, Tracy, and then Linda, and we'll finish with Alice. Brief reflections and your closing comment. Thanks. You're on mute, Tracy, I believe.
Sorry, that was a really, really big question. I think this is everything that we need to start and thread through the SIG, and I think what we need to do is find a way of making sure that we have a communication and conversation mechanism beyond the membership of the SIG. The membership is growing fast within that space. There is a huge amount of interest, and we are drawing interest from all disciplines. So it is an amazing space, but I do think this really does set our work programme in terms of the layers of complexity that we need to cover, and not only answer some of those questions, but actually discover the questions that sit behind those, so we can really start and feed out then to partners in terms of how we can really start to deliver action. Back to that intervention question, how do we start to reframe interventions differently? So I think you've just written my work plan for the year.
All right, thank you. And Teresa Marto, who's also joined the call, wonderful to see so many great colleagues on the call today, has said, tobacco, alcohol, food, and fossil fuel are responsible for 23% of deaths in the European region, and for impact, good industries to focus on. But Linda, what are your thoughts? And getting this balance right between, big drivers of ill health versus emerging industries, and what we need to do. Yeah.
So going back to the examples that I showed, and I mentioned a corporate playbook, I mean, the kinds of companies that we're talking about, particularly very large multinational organizations, the profit motive is obviously, that's why they exist, or part of the reason why they exist, but they have many other reasons as well. So I think going back to the scholarship, we can see that the same tactics and approaches are used by multiple different actors. And I think if those are having a health impact, even if not all of their activities or not all of the parts of the organization are behaving in that way, then we need to take it seriously in public health. So I think we need to be flexible. And it's not just about non-communicable diseases. If we think about the climate crisis and the industries that are contributing to that, that has a major effect on infectious disease as well in the One Health agenda. So I think even though we can't ask Tracy and Alice's group to look at all parts of industry activity, obviously you need to prioritize. I think we are going to see common threads, and let's adapt as time goes on. But as this is my final opportunity to say anything, just really privileged to have Tracy and Alice's contributions. Kevin, to you for chairing, but also, as I said earlier, just the fantastic comments in the chat, and that others can look at the other people's comments, and there's some good links that people have put in there as well. So thanks.
Thank you. And Alice, we'll hear from you in your final reflection. Thank you.
Thank you. Well, I was kind of very happy to say that we do have other special interest groups for these products, right? So we're going to have a tobacco and vape special interest group. We have alcohol, we're excellent, and the food SIG also, and the sustainability SIG. So happily, we have colleagues on the case. And I think for me, this is where that sort of systems thinking really helps. And I think that the key for us is to be working at the level of understanding the cross-industry playbook, the practices that are actually being used by industries to interfere with, good public health policy making. And therefore, those safeguarding policies are the ones that we need in the case where we have an industry, however small it is, who is impacting on health. And I think it's important to kind of just reiterate that that's the whole kind of development piece, I think, around conflicts of interest and being competent in that area. And I think just my closing remark is just to also thank my fellow panelists for their comments and all the questions. It really is a privilege just to be with you today and give you my thoughts. Thank you.
Wonderful, Alice. Colleagues, we've come to the end of this month's distinguished lecture. A huge thank you to our lecturer today, Professor Linda Bauld, for such a stimulating presentation, generating lots of comments and questions and discussion in the chat, but also really insightful reflections from Tracy and Alice. The opportunities for us to come together as a public health family to reflect on different aspects of public health practice, some of which are challenging and difficult, others are emerging and uncertain, is a critical part of what we do here in the Faculty of Public Health. And to be able to engage members, whether academic, whether registrars, whether those who are practitioners working at different levels in the system, are a key element of bringing us together to reflect on our practice and to improve our practice for impact. So a huge thanks to all of you for joining today and for staying with us throughout the entire lecture. Thanks to our colleagues in the faculty for providing the support for this and all other successful webinar events that we host. The recording of the lecture will be circulated with the August edition of the Faculty Bulletin, and the slides and resources from the presentation will also be available as well. Finally, as always, if you'd like to be engaged in the work of the faculty and specifically with the work of the commercial determinants of health SIG, and special interest groups, other special interest groups, we would certainly welcome your participation through our Faculty of Public Health members portal. So participation in our SIGs are open to our faculty members only. So colleagues, thank you so much. We've come to the end of the session today. A huge thanks to our speakers and have a fantastic rest of the week.